and to a poor Brahmin to give a poor responder, that is a good. Because in Panchtantra also, madam, they are not allowing us to become a rich. If you teach any story to any kind or small kids, you are starting with एक गरीब ब्राह्मण. So we are that much poor that we are not so we are not able to become paisadar in Panchtantra also. So my topic is management of poor responders pets. Thank you for kind words, chairperson Mahesh bhai. You see my whole body is dancing. So thank you. This is my credentials and.
Manish, we are not kept in an entertainment program. Manish ने मेरे को पहले से बोल दिया.
क्या बोल दिया?
ये मनीष है तो सर्वर थे.
हाँ सर्वर थे जैसे ना. That's okay. So you can scan these two QR code and you can see my all 116 research work in Orchid and 53 students still passed under me. I have a DNB center at my place. The moment child is born, mother is also born. She is there, but mother is something new. How beautifully everything is arranged by Almighty. Kanti madam, when child born, mother is ready to take care. Sultan may be there somewhere else, but mother is always there. So with the blessings of mother of mine and so many others, 3 book written by us is recommended in Royal College. Atlas of Fetal Echocardiography and Technique of IVF made easy has gone for 2nd edition. I am editor-in-chief of 2 journals, Indian Journal of Obstetrics and Gynecology. It is a Scopus recognized journal and already 60 papers are published by me in this same journal. Open Access Journal, if you want to publish your paper internationally, you can contact me. Work as a KOL in dydrogesterone since 2000 and recently I got opportunity to interview Professor Herman Tourne in X-ray 2023. You can see this video. What is the presentation given to me? Why poor responder are there? What is the causes? How to predict and how to manage? The fact is, there is no definite definition. Usually the ovarian function goes hand in hand. And madam, very beautiful pearls you have designed. 2 beautiful pearls studied with lots of diamonds coming in and outside. And maximum are there at the 5 months of gestation. But it decreases with age. And Mahesh, we are getting later on, but it doesn't decreases with the age. If you see the biological age of a lady, it is 1 year earlier. Madam, you are 1 year earlier than the biological age. So that's the disadvantage they are getting to born with complete. And if you see the female, it is XXY. They are always stable because they have got table. But we are X and Y. That's why we are sleeping here and there because we are putting on a single long leg. So we are standing on a single lane. So you see, that is not our fault. It is genetic fault, madam. You are more steadier person because you are on the grounded. And since birth, Mahesh has told you are complete. We are completing even after the old age. We are not finishing our life. So thank you very much. So this is a biological age, and we all know that ovarian result declines with the age. So how to diagnose poor responder? Only 2 things are decreasing, that is increasing, that is FSH and HMG. Otherwise all AFC, AMH, follicle, estradiol and oocytes all are decreasing with the age. How you consider poor responder? Whether it is a monofollicular growth or small follicles. Still there is dilemma. Why should we know them? Because madam has rightly told, here we have to individualize the protocol. We have to counsel them for the earlier treatment options because so many times we have to add the adjuvant and we have to courage to cancel the cycle or we have to cancel the against the stimulation. Actually our body, we all know that, given very good Bologna criteria in 2011. It says that if woman is age of 40, then previous poor cycle, abnormal ovarian reserve. Then they say that Mahesh, 40 year is too much. So they came with another criteria. You can call it as a Poseidion, Osedion or Osedion because this is a Greek god. And once you write any woman, madam, just don't do anything. For a poor responder, write that you are poor responder, your AMH is this and AFC this. They are using the internet and they came with their own class that I am belong to Poseidion 4, I am belong to Poseidion 3. So use the internet because even though you don't say, they will use it judiciously. Just as the right poor responder, your AFC is this, your AMH is this, and Pujan IVF, you know that they are coming with their criteria. I am suffering from poor responder, so make me richer. So how you predict? You predict with age, follicle count, AMH, ovarian volume, testosterone and prior response. Always try to look at the file of previous IVF specialist. What she had not done or he has not done. Put your one or two thing over that, because even though you can't do much on this poor responder patients. So you have to see, you can give pre-cycle adjuvants like DHEA. Again, too controversial, simple cyst and pre-OCP cycles. DHEA when came in market, it has got a huge response. People are trying to write DHEA to increase the ovarian response. But in 2011, they had given a very good paper that over the times it appears that DHEA improves the ovarian reserve. So you can use this molecule judiciously in the patient, but it should be pre-treatment. When you start IVF and just you say that now DHEA is increasing your volume, no, you have to start it pre-treatment. So when patient comes with poor responder, 2-3 cycle failed, you just start the adjuvant pre-treatment with all the micronutrients you want to give. Again, it is very controversial, but when I was there in France with Professor Manish, they are used to do laparoscopic ovarian cystectomy for endometriosis more than 3 centimeter. Now it is controversial, people want to do, people don't want to do. That is an individualized perception of everyone. Madam, your catchy title is there. I had heard you first in Delhi conference CICOG, and madam has told power of one. For 2 days I am wondering that what is the power of one. Then when he spoke, it comes to a folic acid. It is just like semaglutide. It's just like intrinsic. So it is a power of one. So whenever you want to give a catchy title, does hormonal contraception prior to fertilization negatively affect the oocyte yield? Now it is a controversy. Would you like to give OCP pre-treatment or you don't like to give OCP pre-treatment? That's individualized, that upon you. People say that after giving OCP there is separation of endogenous FSH and LH. Once you start stimulation, it will rebound. It will give the flare-up effect. So whatsoever you want to use, you can use it judiciously. So you have to use adjuvants like GnRH flare, GnRH agonist, antagonist versus agonist, and you can use clomiphene flare. GnRH agonist flare protocol, either you have to give mild or microdose. They prove that the microdose gives you a very good result in poor responder patients. People are used to say, madam says that you have to use antagonist. Here is the only thing, here old is gold. They have done study meta-analysis from 2001 to 2010 that compare all antagonist cycle and agonist cycle, and then ultimately the odd ratio is little bit catchy on the agonist side. So whenever in cases of poor responder, if you use agonist protocol, then it will be very useful. So somebody has used the antagonist protocol and patient came to you, Nisar, you can use. And I am proud that you belongs to my Surendra College as a UG student. Now madam, he is progressing like anything because he has absorbed you also. So in recent essay, we had consensus lots regarding the natural cycle, and I think that Lucy Brown was born from the natural cycle. So now in all this poor responder, you can use the natural cycle and you can take early worms, make them IVM, use letrozole and clomiphene flare protocol, because I've seen so many prescriptions. They are starting with first cycles of letrozole and clomiphene, and then they are adding HMG or recombinant FSH, depends upon the patient's requirement. So in poor responder, what should be the dose? Madam says, I like to use HMG. Then there is a combination between HMG and recombinant FSH. Whether would you like to use LH in poor responder? What should be your stimulation? Whether you want to go for natural cycle IVF, and what is the dosing interval? I had seen prescription patient has started with 600 unit internationally. I stick myself to 450. You can give once daily or twice daily, depends upon the patient's perception or patient's ready to take 2 injections or 1 injection in a day. Role of HMG is very good when once patient has given recombinant FSH in previous cycle and they don't found any good result. In this type of patient, rescue IVF with HMG and you can get very good follicular growth, means 2, 3, 4 follicles, because in poor responder, you never expect more than 10 follicles in each ovary. If it is there, then they are not poor, they are richer. So in poor, you have to get maximum out of that beautiful 2 white pearls. Whatsoever diamond remains, you have to dig out, and you have to dig out, I meant not as a lab grown, as a real diamond. They then become pregnant. Role of LH. it is very good, madam. Nowadays people are adding LH in poor responders. It is in very recent meta-analysis of more than 40 randomized controlled trials. They have proven that if you use recombinant FSH plus recombinant LH versus only recombinant FSH, and they say clinical pregnancy rate is 30% more in poor responders with adding LH into their stimulation protocol. How LH works? LH works at follicular level in dose of dependent manner and increasing in androgen production. Androgen are then aromatized to estrogen and helps to restore the follicular milk. Action of LH at granular cell level enhances the responsiveness of FSH that we are giving from exogenous source, and LH has got direct positive effect on final oocyte maturation. And this all are randomized study from 2017 to 2030, and they say that additional of LH seems to be beneficial in all these patients, those who are at poor response. What is the laboratory option? You have to do ICSI for all or give them the chance of IVF. PGD, what is the ideal day of transfer? How many embryos you are going to transfer, and if you are not successful, you have to give them the option of donor cycle. Question arises. ICSI for all? ICSI for all? No. Yes or no? Then you got only few oocytes, 4 or 5. Then whether you are giving them chance to get married by themselves or you are getting ICSI by forceful marriage. If you give them the option to choose the ovum, and if they are not, then you have to do rescue ICSI on after 12 hours. But it is better to do ICSI for all, and universally it is expected that whenever there is less ovum, particularly in poor responders, when there is ovum age is also big. Now you are not giving any artificial thing like mitochondrial influation or something like that, then it is an old lady. So better not give them the prize that Julia Roberts runaway bride, catch them early, make them marry by forceful marriage of ICSI, then you will get at least few good overs. Then question arises. As such we know that it is an old lady, more than 35, they came to you and now you are putting this all without doing any PGD. They already has exceeded the age. So it is better to do PGD and give them the good euploid embryo, because statistics says that 80% of aneuploidy is coming from women, Mahesh, and only 8% aneuploidy is coming from men. So sperm are responsible for only 8% of aneuploidy compared. It is paper, madam, I will give you. When I am talking any references, it is not without any quotation. Okay, so because aneuploidy are more with aged ovum compared to sperm, and it is fixed in the Cochrane review that 8% sperm are responsible for aneuploidy. So here, because we are dealing with old age ovum, better to do PGD. Then question arises. Joel says I put everything on the day 5. Okay, because day 5 blastocysts are very good. In poor responders, they say that if you put it on day 3 or day 2, chances of pregnancy or carry home baby rate is very good, because you are putting them in a own environment, own milieu, in a good, when there is a very good pinopodal activity, when very good intergreens are there, alpha B beta 3 intergreens are there, endometrium is very good, endometrium is receptive, because we all know either if we are done PGD, we are putting them in a very good endometrial primed cycle. So when there is endometrium is good, we are putting very good ovas. So at that time, what do you like to give for day 2, day 3? And evidence says that if you put on day 2, the chances of carry-on pregnancy rate is very good. So again, old is good. Again, you have to use agonist cycle. Again, you have to do earlier transfer to get very good results. And they have proven that in day 3 embryo, the carry-on pregnancy rate, the rejection rate, and live baby birth rates are very good compared to day 5. If you are not successful, when there is no surrogacy law came, we all are here to give them the option of donor cycle. In next 5 years, madam, all poor responders, since last yesterday we are reading very good name of genomic, proteomics, metabolomics, all mix to have a very good stimulation role in all protocols. Yes, madam, ovarian drilling, 4 puncture, 4 millimeter deep, 40 watts. That should not be an ocean. You have to see the ovarian volume and you have to do ovarian drilling. Whether ovarian drilling is helpful in poor responders. Evidence says no evidence that one modality is superior to other. Suggestion that resumption of ovulation is temporary. It may cause adhesions. If you have done, as well as rightly told, it is not drilling, it is a grinding. So if you do a grinding, then the whole follicle will go and 100% chances of adhesions are there. Cochrane review says there is no significant difference in pregnancy rate between laparoscopy ovarian drilling and gonadotropin after 6 to 12 month follow-up. But caution should be there about the ovarian drilling, and if you find good result, you can do it. For poor responders, ICSI is best. These are the protocol everybody knows, but here is the difference that in agonist or antagonist cycle, from day 6 onwards, you have to individualize the protocol. You have to see that whether your giving dose is giving you very good recruitment of follicle or that, because already follicle are recruited in day 5. Then there is increase in the size of follicle. If there is very good cohort is there, then they are going to become big. If babies are there in the kindergarten, then the baby will go into the college. If baby are not born and they are not into the kindergarten, they don't go to the college. So don't expect that after 6 or 7 days, new follicular crop will be there. So you have to dare to cancel the cycle on 6th day or 7th day after adding FSH and gonadotropin. So you have to see that this is a tricky situation in poor responder, that don't give continuous dose. You have to counsel patient properly that whenever needed, I may choose to cancel your cycle. Then from next cycle onwards, either we add something or we do something for you. What is considered poor? Less than 4 follicle, 5 follicle from both the ovaries, and sometimes they have got only 1 or 2 follicles. This you agree. But even this 1 or 2 follicle, we are giving them good chance to become pregnant and do good chance to become their own progeny. Young woman with poor responder has got very good quality of embryos and better chances to getting pregnant. Increasing gonadotropin does not significantly improve. You can increase from 450 to 600 or 300, 450, 600. It is not going to beneficial. If you are hungry to have, Vivek has said 4 chapati and 2 chapati, and if you give them 8 chapati, they are not able to digest them. So treat them judiciously, don't overdose with. Why to cancel the cycle? Explain the reason. Give them hopes that I will try my level best and we will add something in subsequent cycles. In subsequent cycles, use gonadotropin dose increasing from the day 2. Because whenever follicles are recruiting, Madam has rightly said, their assistant had given them the choice of day 3 to 7. Why are giving clomifene, letrozole, gonadotropin from day 2? Because we know that in early follicular phase, follicular recruitments are there. If you start clomifene citrate from day 5, it is only going to increase the size of follicle. But if you start any gonadotropin or any aromatase drug early in the cycle, you will get very good number of follicular crops. So start with good dose in the first. 450 is the ideal dose. Protocols, you can use long protocol, microdose protocol, clomifene citrate, GRN antagonist protocol. Here you can use flare-up protocol, exogenous FSH administered on day 3 and continues for the follicular stimulation. Completely pituitary desensitization is done. Ultrasound only give flare. Give the ovary just stimulation. LH should be suppressed till the mid-cycle, and you have to very low risk of premature LH surge. In growth hormone, you can add it. It is an adjuvant. Natural cycle, again now it is getting more and more importance. You have to predict all poor responder with all these hormones and AMH. AMH is very helpful. Just do AMH. Previously it was very costly. Now everybody is going for AMH. You can do it in any cycle. If you are competent enough, just like Dr. Nagori, you can still try poor responder with gonadotropin and you can go for IUI because patient may have fed up with IVF. If in IVF, do good stimulation, modified natural cycle, antagonist, agonist, and if you are able to grow them in your lab, you can go for IVF. So in summary, modified stimulation protocol, adjuvant therapy, conventional agonist protocol is very good. You can use mini dose protocol. You have to stop protocol at any time. Use short and ultra short or flare protocols, and microdose flare protocols has got very good importance. Keep in mind that adjuvant therapy with growth hormone, androgens, Short, soft protocols, recombinant LH, L-arginine and steroids and aspirins, they are very good. You can use OC pills, estradiol, and these are the management protocols. Here, the dual stream protocol is very good nowadays. It has got very important. You can stimulate the ovary in the first follicular phase, take the OVs, again stimulate again. You do the 2 follicular cohort in 1 cycle, take good quality of OVs, go for PGD, and you can go for FET cycles. Disadvantage of dual stream is you cannot transfer in the same cycle. You can use gonadotrophins, you can use GnRH agonists, GnRH antagonists, microdose flare protocol, natural cycle, you can use luteal E2 protocols, and recently we can do everything on this white pearl, PRP, ovarian stem cell therapy, and Dr. Sunita has designed the Society of Ovarian Rejuvenation, and we are giving stem cells to that ovary, and recently we will publish that paper on stem cell uses in ovarian rejuvenation, and we are getting very good results. So in poor responders, it is not uncommon, it is common. You have to diagnose with Logana and Pasodian criteria. Modified protocol use adjuvants. There are no single best protocol. Expectations should be discussed with the patient, and it's preferable to opt simpler, less expensive regime for ovarian stimulation. So main need is difficulty, Manish, because they want to necessarily enjoy the success. Without difficulty, you are not able to enjoy the success. So here is the success. If you have got very good work, you will be there on the GIF of so many company. 80 company are using our paper on dydrogesterone. So the time to be happy. That is it.
Thank you, sir. I think 1 hour lecture will be completed within 20 minutes.
Thank you.
And the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right.
Patients are poor responders or physical patients. You have to give them the help.
Time.
Thank you. Thank you very much for patience here.
Thank you, Dr. Manish, for a beautiful presentation.
Off करिए दो.
We all know he's an excellent speaker, but today we have seen another talent of his, that is our artist.
Off करिए.
So moving forward, please join me.
Thank you.
Yeah.